Welcome to another episode of Let's Talk Health. I am your host, Casey Ricks.
And I'm Dr. Shannon Ricks, family nurse practitioner. Today we are on our second podcast of our discussion on disparity of maternal mortality rates among Black women. We have a special guest, Fabeola Sepolen, who is a adult nurse practitioner and women's health nurse practitioner. Go ahead and introduce yourself to the people.
Hey guys, my name is Fabeola, and yes, I am a nurse practitioner. I specialize in women's health as well as adult primary care, and I'm glad to be here with you guys.
All right, and we're definitely glad to have you on here to discuss this very important topic of women's health and giving birth and the death rate. And as I said in the last podcast, I personally didn't know that this was an issue until a couple of years ago when I saw it on the news and they did a special report on it, and it blew me away. So I'm definitely happy and excited that you are on here to help us address this issue and everything. So I'm going to go ahead and get started with our first question. How does expansion of healthcare coverage and access to healthcare coverage help women's healthcare needs across a lifespan?
So that's a good question. So I would actually take it back to what the Affordable Care Act did for the expansion of healthcare. So going back to Obama's administration, he obviously put in the CARE Act that would affect a large number of people as far as their accessibility to healthcare. And it did three main things. So it did help with expansion of the Medicaid program. It helps with cutting down or improving the premium tax credits for a lot of people. And it also kind of did a reformation for the private insurance companies. So when it comes to women, it helped tremendously. So if you want to start with Medicaid, it would previously, not Medicaid, would start with private insurance. So with private insurance, typically before the CARE Act, when women would apply for private insurance, there would be a lot of issues with their ability to pay because they would be charged at a higher rate than men for the same level of coverage, and which is a real thing. So that the CARE Act actually took that away. And they would also be denied of insurance coverage because of pre-existing conditions. So, and not just like medical problems. It would be like if you were pregnant or you were having newborn care, if you had mental illness issues, mental health problems, or even just preventative type of services, they would be denied of those rights with the private insurance. The CARE Act, that was removed as well. I know now with the Trump administration, there are some changes that are kind of drawing back what was approved previously. So now with the Trump administration, he did draw back some of the services that would take away that stipulation of pre-existing conditions. So now with a lot of private insurances, you can actually still be denied because of those pre-existing conditions, which is a drawback for a lot of people.
Wow.
With Medicaid, yeah, it's
wow.
pretty bad. So with Medicaid, some of the improvements, well, just in general, as far as your eligibility for Medicaid, traditionally, you have to meet a certain level of poverty in accordance with the federal poverty level. So the income is a big factor, but you also have to be in one of a few categories. Either you have to be pregnant, you have to have children you have to be raising children, caring for children that are 18 years or under. You have to be disabled, or you have to be 65 years or over. So with the expansion of Medicaid under the CARE Act, they actually did take away some of those requirements. So now, not only did they raise the bar as far as what your level of low income would be considered. So for those that were making a little bit more money than the previous, stipulation, there's more approval for people because, they just didn't make the mark. And also that all of those categories, they don't necessarily have to be in one of those categories. It's really just the income that they're looking at. So which has opened doors for a large amount of people, especially for women. Also with Medicaid, generally, if you were pregnant, you automatically are eligible for what we call like the pregnancy Medicaid program, to where you have access from prenatal care. And then generally, once you have the baby, you have that coverage for about 60 days after the baby's born. But now with the expansion of Medicaid under the CARE Act, that coverage can continue even further than the 60 days. So as long as you still meet the mark as far as your income level, you can still have that same coverage, which is beneficial for a lot of people. And generally, just speaking on my experience, we had several people, and when I was working OBGYN, I was in Macon, Georgia, which is typically very low income families. So I had a lot of people that were under the Medicaid insurance for pregnancy care. So that was just like vital for them. So just having that peace of mind that you can continue that coverage even after you're done having a child, like it does take a lot of stress off of people. When it comes to like as far as coverage for other people, it's beneficial to know that under the CARE Act, they did expand the ability for adults that are 26 years and under to still be accepted under their parents' insurance, which is helpful for a lot of college age students, people that are in their early 20s, starting their life. They don't have a lot of money, so that's really beneficial for them.
Mm. So you answered the second part of that question. So one thing that I keep hearing is that how the Affordable Care Act has benefited so many low-income people, people in general, but especially those in the low-income bracket and everything, and how it has improved. And the importance of healthcare when it comes to dealing with this issue, especially because if you don't have a good healthcare coverage, it can add to and cause stuff like women dying or whatever the case may be from not having that coverage. And I don't know how doctors work, but they probably look at your insurance, seeing if you can afford something, and they don't, do whatever it is if they don't think you can afford it. Is that correct?
No, that's very true, actually, especially if you, I mean, and Shannon can relate, if you have someone that comes into your office or someone that you've been treating for a while that doesn't have insurance, but they are in need of services, like say they come in with a specific issue and you're concerned about A, B, and C, but there's only so much you can do because those things cost money to figure it out, or those things cost money to address. So if they were coming in with something going on like during their pregnancy, or even if a female came in with concerns of, vaginal health, for example, like say they think they got an STD, or they think, their partner cheated on them or something, I can address it, but I can't necessarily go ahead and do cultures like vaginal cultures or blood work because they don't have money. So, and labs cost money. So I'm not going to have them be even in more of a troubled situation that they're having to pay for a $500 bill for their lab. So the only thing that I can do really is just sometimes you can empirically treat. So assuming that they have something going on, you can give them something and hopefully that it will clear up. But in general, to kind of give them a holistic care and to kind of like be just to kind of give them that treatment that they need, it requires certain things that cost a lot of money. So I agree with that completely.
Yeah, and I don't think, before I turn this over to my wife for the next question, I don't think we as Black people understand just how beneficial the Affordable Care Act was to our community and how in so many ways it has helped us. I don't even think a lot of people know what all the benefits of the Affordable Care Act and how it has expanded and improved the healthcare system. Although you got a long ways to go, it's better than what it was before. And if that is undone, it's going to do great damage, not only to the healthcare system as a whole to make it better for people, but definitely for the Black community. So
I agree.
I think when we talk about coverage gap in Medicaid, you touch on the point of where you used to work as Macon, Georgia. And I have been to Macon, Georgia, before, and it is, the kind of low income, but it's also, a lot of Black women live in the South.
Right.
So a lot of Southern states have chosen not to expand and certain things like that. So that does play a part into us specifically because that's where we're prominently located, is in the South. So I think they were saying, like, some resources were saying, of course, that that's the areas in the South where we experience poorer health outcomes because of the coverage gap, where women fall in a gap because they either earn too much to qualify for traditional Medicaid,
Right.
and then on top of that, they don't earn enough to qualify for Affordable Care Act, that insurance marketplace as well. So then it becomes a lack of access to insurance altogether. So I think how that impacts us, is a key thing to consider too. It's where we are predominantly located.
Right. I
In
agree.
the country is in those areas too.
I agree. And just I mean, speaking, just kind of touch on my experience, like when growing up because I grew up in Minneapolis most of my life. So when I moved to the South, it was a it was a culture shock. It still kind of is a culture shock, because we've been living here. I mean, we live in the Atlanta area since 2010, pretty much, with the exception of moving a couple times. But like, even in the Atlanta area, you will find those areas, those counties that are definitely low income, and even touching on the Macon area, there's kind of like, when you go to Macon, it's like there's a legitimate railroad that goes through Macon, and on one side of the railroad you will see those low income, mostly brown Black people, and then on the other side of the railroad you will see those more affluent people that have lived there for years, or they have come here with money and they have kind of established themselves. So like, it's definitely a
Interesting.
yes, and I agree with you. I mean, being in Macon, there is I can't say Macon is a desert as far as healthcare, but I know that it is limited, and when it comes to maternal health. So it's very kind of sad to experience sometimes.
And you're touching on I think one of our questions touches on maternity health deserts.
Mm-hmm.
So we'll, I guess, expand that in a little while. But how would, you may have already talked about this, but how would expanding paid and family leave affect Black women in maternal women's health needs?
So I think it would help tremendously. I mean, if you think about it, there are a lot of Black women that are the head of the household when it comes to how they are raising their kids, how they're taking care of extended family. And most of them are, not most of them, I can say, just based off of the census that I looked into for 2019, there's about 69% of children that are now living in a single family household that are mainly Black women. So just the large majority of our families are in need of just accessibility to just basic care. So just having that ability to, be able to raise your children, have your babies, and have that time that is necessary to care for those things without having to worry about your income. I think it's beneficial. If you look at other countries, I mean, there's been documentaries all the time about how places like Canada and other countries have seen so much growth overall and so much improvement in the lives of their citizens if they were to have just that ability to not stress over maternal and paternal leave from their jobs.
Yeah, all right. How would investing in healthcare safety and quality improvement initiatives impact Black women's health?
So I think it would be beneficial. I think it would affect their, you're talking about like the quality improvement, you said?
Mm-hmm.
It would affect their outcomes when it comes to going through the delivery process, going through the maternity process. I feel like overall, those types of initiatives. So there's ones like, the Alliance for Innovation of Maternity Health. There's California Maternal Quality Care, those are like federally funded initiatives that will help to standardize the care of maternity patients as well as those that are in the delivery process. Because as we all know now, that we are disproportionately affected by maternal deaths. So, and most of the time it will happen as a result of either they need a certain type of care and they are denied, or they need a certain type of care and there's a delay in action to do that. So with those initiatives, they are helping to kind of standardize protocols and standardize safety precautions that will have things in place. So when you, as a patient, you go to the hospital, you are rest assured that, during your delivery time, if something goes wrong, they already have protocols for that. You're not going to, the goal is that you're not going to wait until it's too late to address an issue, or you're not going to be denied when you feel like something is wrong. So I think that would help tremendously. And I know you touched on a little bit about the notion that, in your previous podcast, the notion that as Black women, we are disproportionately not catered to when it comes to pain during delivery, just because I don't know if it's just an old, thing that is taught down from generation to generation when it comes to how we handle pain, how we express pain, but we feel pain just the same. And I think that has been a disservice to not only our generation of providers, but also generations before us, to really kind of gather how we are so unintentionally biased to Black women when it comes to them being in the hospital or being cared for in general.
Yeah. And that is very obvious. I mean, just had an article a couple of weeks ago, and they was talking about this very issue, that Black women have a certain percentage, a worse chance of dying if they go to a white doctor than they would if they went to a Black doctor. That is troubling, because I don't know how many Black doctors there are, but from my experience, you don't really see a whole lot of us in the hospitals when you go in there. So if that's the case, then it's like
right. And I mean, and obviously it goes past just race, but race is an important aspect because a lot of people are not culturally competent. Just being, even if you were a doctor for 30 something years, like that doesn't necessarily mean that just with your experience, you know how to relate or how to appreciate each and every different culture that you come across.
Exactly.
So I think that's important to note, but also just being able to be comfortable with your provider. And I tell people all the time, like, if you don't feel comfortable with your person that you're seeing that is supposed to be taking care of all of your health needs, or at least leading you in the right direction in order to do that, then you need to change, or you need to at least ask for a second opinion. Because you as a patient have every right to change doctors or change nurse practitioners or change PAs. Like, you don't have to stick with that one person just because maybe they are the one far and few between that are covered under your insurance, or maybe you just don't have the time to research someone else. But I mean, it's, at the end of the day, it's up to you.
Yeah. Well, and I always say that too, because, sometimes it's not the race all the time. Sometimes it's just personalities.
Exactly. Like, you may not mesh well with that person.
Yeah, you just may not, different views on how to approach healthcare or the health, so like there's other things. And I always say that to patients, like, you don't have to necessarily be mean.
Exactly.
You know what I mean? It's okay to just say, it just isn't working. We just don't see eye to eye on certain things. Maybe you may need someone who's more nurturing. You may need someone that has dealt with complicated pregnancies before. You know what I mean? Like it's okay to kind of do an interview of a few to see. Now, I will say this: where you are located, there's a plethora.
Yes,
Yeah, you are in the mecca of Black professional doctors. Yeah,
where I am.
like there's a plethora of options.
Yes.
But what we're going to get to later is that there are deserts too.
Exactly.
Where sometimes it is what it is, and you
Right.
don't get who you get.
Yep.
And it's just.
Yep.
And I mean, and then if you social determinants of health, your transportation is not there.
Right.
Sometimes you just gonna have to, you get what you get. You know what I mean? Sometimes it's the hard truth, and so we got to come to some type of pathway of agreement, I guess, on how to approach it. But I had a question regarding pregnancy discrimination.
Okay.
Have you, just throwing it out there, when we talk about protections for pregnant workers, that they were saying, especially for Black women, when it comes to pay, when it comes to the insurance, that affects us in more ways than one, because of course, if your insurance is attached to your employment, and then for whatever reason you get demoted or you get laid off or whatever the situation is because of the pregnancy, or because whatever they had to take you out for a high risk pregnancy, extra length of time, that some women are also being discharged from their job too, which now you've just lost critical income and access through your company's insurance. You know what I mean? So now here you are going through so many months of your pregnancy, and all of a sudden everything has changed. Like you get dropped from insurance, you got to find somebody else. That creates a conundrum too.
Sure. And that happens a lot, actually, just because, especially now, with not only just the way the economy is currently, but also with COVID, it has drastically changed the sustainability of the job market, basically. So for women that are in that situation where they have, for whatever reason, they've lost their job, that's where the Affordable Care Act actually comes into play for those women. So the fact that they are able to establish themselves under a Medicaid program because they're currently pregnant, you would just need to go online, and all of the government sources are available for you, to where you just go online, apply for Medicaid, and you will, for the most part, for most people, you will be covered. I can't speak on everyone's situation as far as their level of income, but that's where I would direct you initially. Moving forward, you can always, if you're still on the market for finding another job, the discrimination is still there, which is just, it's just bogus to me, because women support this nation. So the fact that they are pregnant should not be an issue. I can understand in certain situations where the type of work that they do would be at a liability to the employer just because of the fact that they're pregnant. But in a lot of circumstances, it's not. But they will still be discriminated against. So that's something that still we need to address as a nation. But as far as the first step, I would say go online or go to some services that can help you to apply for Medicaid, which will at least give you a one standing chance of getting that coverage. Because there's a lot of people that I will see, they hadn't had any kind of insurance, and they'll show up 5-6 months pregnant. And by that time, in a lot of cases, if they're having certain issues, it's already a little too late. We can just play catch up, essentially, and just kind of manage what we can manage at that point. But it's definitely important to, as soon as possible, to try to get back in for that prenatal care.
Okay. So we what are maternity deserts? We're going to finally jump into it. So what are maternity care deserts and how can we eliminate them?
So maternity care deserts are places, typically counties, that will either have a lack of a hospital that has no OB care, or they will not have any available OB providers. So in a lot of cases, those turn out to be like rural areas, because like you said, there's a lot of, healthcare facilities that are few and far between in the rural population. So for many people, you have to drive like hour plus just to get to your provider. But it happens even in in urban settings where, say, for example, you have a hospital that shuts down their OB unit to where you don't have access to that facility, or you have OB care providers, but they're all full. So you have to wait weeks and weeks before you can get in. So it does affect both cases, but a lot of times they're disproportionately affecting the rural areas. And even now, I think there's, like in the states that we're at, like in Georgia, I think there's about 20 something percent, I want to say 24% of those who are not, they're uninsured and they're not in that space where they can have access to care. I think where you guys are at in the Carolinas is about the same amount, like the 21 to 24% as well. So there's a lot of people that are being affected by this, but we're still having babies. Like there's 150-something thousand babies being born every year. And so just imagine the amount of people in that population that are not being seen during their whole pregnancy. So it's something that needs to be addressed. A lot of people in a lot of areas, they are trying to address the transportation issue, which makes it a big concern as far as how you're able to gain access to those places. They are, I think, incentivizing providers to live or at least work in those areas would be somewhat of a potential possibility. So that way, because most of the OB providers live in the urban areas, they live in the bigger cities. So there's no real incentive to live or work in places that are more country in the cut somewhere. So if you were to kind of give them some more incentives, I don't know if maybe whether it's an income incentive or it's a a package benefit deal or something, to where they would kind of be more inclined to go in those areas. I have heard of some places that are offering some more telehealth possibilities as far as, for those people that are unable to go to a place very often, but they just need that general talking to somebody or checkup that, obviously we can't physically examine, but at least we can check up on them, talk to them, see them face to face on the internet, kind of address their concerns, because there's a lot of people that even if they've had a baby before, they have a lot of concerns with this other pregnancy, and every pregnancy is different. Even if you're the same person and you've been pregnant 4 times, that 5th pregnancy is going to be completely different than your other ones. So a lot of people will come in with questions, and it might be simple to you, but it's something concerning to them. So just being able to have that access to talk to somebody, I think would be helpful as well.
Good. That's I didn't know that there was a maternity care desert. I'm learning something myself with this podcast. So I definitely appreciate that. I know there were places where, hospitals and all this stuff, but I didn't know the maternity care desert was a major problem like that. So that was good to know. How can we increase range of birth options?
So that's a hard question. I know right now there's already different facilities outside of the hospital that people have babies. So obviously there's, home births, there's standalone facilities, which are mainly run by midwives. There are, which will be like the birthing centers. Right now it's really a federal and state issue as far as just the accessibility to those places. I think one thing that would be helpful is the continued research data that we're gaining from in comparison to these places versus a hospital setting for births, just to kind of show and prove their validity and show that, this is a safe place if you are having a low risk birth, because that alone would kind of validate that space that, in comparison to the hospital, you can go here and you might gain more access to these places versus a hospital. So say you are in a desert or something, and you have access to a birthing center, just having that federal backup to say like, hey, this place is fine, and you, in a lot of cases, you will have a successful outcome when it comes to your health and the baby's health. But we need that research. And I know a lot of places, a lot of people, I should say a lot of organizations like the National Institute of Health and the CDC, they're already, on the ball as far as making those research, those research type of things accessible, as far as, just kind of looking at the data as far as what the outcomes are. So how healthy is a mom when they're having this birth? What access do they have to certain things that they need as far as IV fluids, or say they have emergencies? I mean, do they have access to someone that is capable of providing that care during an emergency? So a lot of factors go into play when it comes to how we can expand these places in our region. But I think it starts with the research, to kind of give, the government that okay, and by default they will assist with, funding the necessary supplies that they need, funding the staff that they need, just being able to have those places just as a same level of care for those low risk pregnancies.
Okay. What are some, I think you've touched a little bit on this, large scale initiatives to address this issue that maybe people just don't know or can look up?
So, yeah, basically like looking into the studies that certain organizations have already done. So there's a lot over the last few years from CDC and National Institute of Health that have really kind of used comparisons as far as health outcomes of these particular individuals that want to go to a birthing center or want to be maintained with a midwife versus an OBGYN. And not to say that it will at all like substitute the need of a hospital, because obviously we need hospitals for very specific cases, but it will allow that accessibility to expand. For those that don't have, you don't have a car, or you don't have access, you don't even have a hospital where you live. So just allowing that research to take place to kind of grant that stepping stone for people to build more of these places is necessary. So really just kind of looking into those major organizations and looking online, looking at their websites. It is accessible to the public. So if you wanted more information, they have it there.
Yeah. So our final question for this episode is, what are some community initiatives that we can activate to address these issues? And I'm gonna throw one in on you. What can the church do to help address this issue?
Good question. So as far as in general, I still think on larger scales, I mean, obviously wherever you are in your community, I still think that just getting the word out there is the most important. A lot of people, like how I commend you all for doing this podcast, because a lot of people just don't know. So just being able to have maybe like a health fair on a regular basis, not just like a, one time every 5 years type of thing, like a health fair on a regular basis to kind of get the word out there, get some resources that you can put in people's hands, give them resources that you can direct them to as far as whether they need, as women, we need a lot of things that we're not really gaining access to. We need a lot more access to contraceptive management. A lot of people don't want to get pregnant, but they just don't have access to the ability that will help them to not get pregnant. And by default, that will lessen their negative risks during pregnancy and during the birthing stage. I know when I was working at the OBGYN office, there was, I think it was a local, I don't think it was through a church, but it was a local initiative. There was a program that every year they would have a fundraising that would bring in a local radio talk show, and they would advertise it. They would put it on, they put it on the radio show, and it's basically to raise money for funding for routine mammograms. Because in Macon and in various other places in the U.S., there's a discrepancy with the amount of people that are getting those routine mammograms, plus the amount of Black women that are being affected by late stages of breast cancer. So when it comes to just having that word out there, I mean, that's big noise. You have the radio talk show host is talking about it on their radio station that is very well known. You have it going on every year, so something that the community knows about and they look forward to, and they have that legitimacy because they continue to do it. They continue to raise the money that they need, and it provides for a certain number of routine mammograms, which can be very expensive without insurance coverage. So I think just getting the word out is extremely important. Getting them access or resources to those facilities that can give them, the contraceptive health that they need, the STD screening that they need, family planning conversations that they need, because it's just so vital. And I want to say, like, in reference to men's health, of course, men's health is important, but a lot of times we end up having the lesser hand when it comes to access to women's health versus men's health. It is very easy, typically, for men to gain access to testosterone therapy or things for erectile dysfunction if they have the money for it, granted. But it is a lot more difficult for women to gain access to contraceptive health, which is important, which is backwards to me, just side note, because everybody is trying to be pro-health, which I accept that, but you're not allowing for those facilities and those management options in order to prevent pregnancy. But you want to offer more things to help with erectile dysfunction. So I just think that's backwards. But just going back to my point, just reaching out to the community, just allowing them to have access to those things that they don't know are there is really important.
All right. So thank you so much, Mrs. Fabeola Sepolen. I was like, Lord, don't let me mess up her last name. I've been saying it so many years. I said, okay. We definitely appreciate you for coming on and being with us this afternoon, and for just the information that you have given us and enlightening us. I learned something. I will learn something every podcast, because y'all are the experts. You and my wife and other healthcare professionals be on here. I'm the one that's sitting here learning, and I'm appreciating what I'm learning. So we definitely appreciate you for being on here with us. And for those that joined us, thank you for joining us again on another episode of Let's Talk Health.
Thank you, guys.